vaguely we knew that looks like a, which we called as Tommy appearance and all those. That yes, this is different from other effusion. Probably this effusion is different than the. So those photographs I have, I'll send you sometime. That beach ball appearance in arthroscopy.
Yes. That's fabulous.
Sorry to interrupt, sir. I'm really sorry to interrupt. We are going live now.
Okay.
So I think we'll start the session.
Yeah, please do.
Yeah. So good evening, everyone. Welcome to the second meeting of the MSK USG Special Interest Group. Today we have a special meeting where we have a talk by an esteemed faculty on ultrasound and crystal arthritis. To introduce our speaker today, I would like to welcome our chairperson, Professor Lieutenant General Dr. Ved Chaturvedi. I don't think so. This audience needs an introduction for Dr. Ved. So there's a long list of achievements and accomplishments. But for the benefit of Dr. Ralph and others, I would like to just introduce Dr. Ved. Sir has been the ex-president of the Indian Rheumatology Association and Delhi Rheumatology Association. He was the first rheumatologist to use biologics in India, first rheumatologist to pioneer in musculoskeletal ultrasound in India, and he's been the recipient of presidential award, the Param Vishishta Seva Medal. Sir is also the vice president of APLA, that is Asia Pacific League of Against Rheumatism. I would request Sir Dr. Ved Chaturvedi to kindly introduce our speaker today.
Thank you, Dr. Jain. Thank you for the honor. And I feel proud in introducing a very great person, Dr. Ralph Thiele from the Department of Medicine, University of Rochester. And he's, the subject which is speaking very close to us. Basically, ultrasound. Look, earlier we were taught that the gold standard for diagnosis is probably take the fluid and see for the crystals. By and large, if you ask the patient, and especially putting a needle in the first MTP joint, which is commonly involved, I can tell you it's not an easy game. We have been doing for 40 years rheumatology. It's not easy job. If large joint is there, knee, still you can put a needle. If a ultrasound can, it is something like when you use ultrasound for rather than lip biopsy. Now, in Sjogren's syndrome, nobody wants to do a lip biopsy. If you do an ultrasound of the parotid, you can pick up. So without much ado, I don't have a formal introduction of this, but I'm very sure he's such a well-known person. I'll request Dr. Ralph Thiele, if somebody has a formal, he can go ahead, but I have this slide. So I'll request him without much ado that he must, so people are waiting for him. Let's listen to him on ultrasound in diagnosis and management of crystal arthritis. Dr. Ralph.
Thank you very much for this kind introduction. This brief lecture will be on ultrasounds in diagnosis and management of crystal arthritis. And as you said, I work at the University of Rochester in Rochester, New York, as a rheumatologist and as faculty. So this is what I want to talk about, the sonographic features of gout, including the double contour sign, what is a tophus, and you mentioned a snowstorm appearance with arthroscopy, so I'll mention that as well. And then erosions caused by gout. And then what else could this be? If we pick up crystals, could this be osteoarthritis or chondrocalcinosis? And then I want to compare ultrasound with other modalities in diagnosing crystal arthritis. So this can be of interest because the American College of Rheumatology and also EULAR have come up with new guidelines or recommendations for classification. And in red here, or in the red frame, they do mention imaging findings, and they mention in particular ultrasounds, double contour sign and ultrasound, or also DECT, that stands for dual energy CT scan. So here's a case that you mentioned some nice cases, but I also want to present a case why this can be of interest. So this on the top is an image that the primary care provider, the GP, has obtained. The patient came to that doctor and said, I have bad pain in my great toe. What is this? Is this gout or something else? And then the doctor said, well, let's get an x-ray. This is the radiograph. It really doesn't show anything significant. And then he said, let's get a uric acid level. If it's high, it can be gout. If it's low, it's probably not gout. That's what our colleagues often do. And then the level was 7, so neither high nor particularly low. But you have an ultrasound probe in your office, and this is the same patient, the same location. You place the probe on the big toe, and you see the metatarsal head. I don't know if you can follow my cursor here, but there's the metatarsal head, the proximal phalanx, and then inside the joint there is this bright hyperechoic material. So that's not quite normal. So you have the sense that this may be gout, because synovitis would look different. It would be a little bit darker, and you might see hyperemia. If you look with a different machine, this is the same patient. We tried just another machine. You see this kind of salt and pepper appearance of this material inside. It's a little bit inhomogeneous, and if you push your Doppler button, there is some blood flow around this, so there's some hyperemia adjacent to the structure. And there's even a little bit of a dark rim around the structure in a person with tophaceous gout. So the ultrasound gives you a different picture, different information from the radiograph, because tophi are we call this radiolucent. They cannot be seen with X-rays typically, unless they calcify. So these are definitions on the left, and on the right are images for these definitions. So that's what I want to talk about. These are the Omerect definitions of findings in gout. A double contour sign on the right is a hyperechoic band that is bright, and then deep to that or under that is this anechoic or dark band of cartilage. Cartilage contains a lot of fluid, so it doesn't really reflect the sound waves. And then you have the hyperechoic outline of the bone. And tophi on the right are typically often circumscribed, often ovoid or oval-shaped or rounded structures, and they can have an anechoic rim. Aggregates or snowstorm that you've mentioned can be these small spots that are embedded oftentimes in the synovial tissue or in free fluid. And then erosions similar to rheumatoid arthritis, although they look different in gout, are these typically punched out lesions, sometimes called a rat bite lesion, and they can have a marginal overhang, as you see on this image on the right lower hand corner. But there's no synovial tissue that's going into this erosion, causing the erosion. So we'll start with the double contour sign. On the right upper hand corner would be an arthroscopy, or if you open up this joint, you see this kind of orange or peach color or salmon color surface of the cartilage. And on top of that is this bright material. Some people call this icing or urate crystal icing. And on the bottom of the slide, you see the first metatarsophalangeal joint. This could be any joint though, that has there's really a rough layer. There's this kind of bright outline that's overlying this dark area that is hyaline cartilage, and then on the bottom would be the bony cortex. So it's the double contour means you see a contour of bone, then there's cartilage that doesn't look like anything, it's just black, and then there's another bright outline or contour of a layer of uric acid crystals. On the left side, on the upper left, is the person that has a double contour sign. On the right side is the same joint as MCP3 of the unaffected side. And you see that there's this bright outline that has a little bit of a roughness to it. And then there's this darker structure, which is cartilage. And then there's, again, another bright outline of the cortex of the bone. On the right side, you see a little bit of a bright reflex. This is where the sound waves meet the cartilage in a perpendicular fashion, so they're being reflected. But the other sound waves that meet the cartilage are being reflected away at an angle, so they do not give you a lot of sound energy back to the transducer. So you see a bit of an interface reflex, but you don't see this rough band of crystals that is typically caused by uric acid crystals, by deposition of uric acid crystals. This is the same joint on the top, but on the bottom is a different patient that outlines the differential diagnosis, which will be an interface reflex. So this is a bit of a complex picture image. This is a person with rheumatoid arthritis, and you see on the bottom the bony contour of the metacarpal head, and then you see the proximal phalanx. You see this bright outline of the capsule on the left of the image on the bottom. Is synovial tissue that's breaking through the capsule and extending a little bit between capsule and tendon. But you also see some anechoic-free fluid inside this joint. And if you look deep to the fluid, there is an interface. That's just the interface between the anechoic fluid and the anechoic cartilage. So for example, if you have a glass of water and you pour oil into it, or vice versa, it'll eventually form an interface between oil that may be clear and then water that's also clear. But the difference of impedance causes this interface. And that's what you see with ultrasound. But you see it's kind of smooth, it's not really rough, and it ends where there's synovial tissue. So there's not as much of a difference between cartilage and the synovial tissue. And if you want to see if patients are getting better, you can place your ultrasound probe again on this joint, and then again when the patient comes back. So in the middle image, there is a relatively faint double contour sign in a person with gout. And then we treat this person with urate lowering medication, and we're able to bring the uric acid level down to less than 5 milligrams per deciliter. And then after several months on the bottom, this goes away. So the double contour sign is sensitive to change over time. This is a different condition now, CPVD disease. You see that on the bottom, you have the bony cortex, then you have this dark area of hyaline cartilage, and then you have crystals or bright material that is sitting right inside the cartilage, basically in the center of the cartilage. And that's different from gout. If you look at the same patient's X-ray, the radiograph, you can even see those calcium crystals, because calcium is typically seen on conventional radiographs on X-rays. But tophi from gout to facious material is typically not seen on radiographs. That's another way to distinguish the two. This slide on the left, I don't want to go into details, but it's very interesting because it shows us, this is from a review article from the New England Journal from 2016. This shows us that calcium pyrophosphate crystals are actually formed inside the hyaline cartilage or fibrocartilage. So in this cartoon on the left, the light blue area is cartilage, and then in the middle, the more orange or peach color area is the synovial space, the joint space, and then on the right lower end corner is synovial lining. So those CPVD crystals are formed inside the cartilage, and then occasionally they can break free and enter the joint space, and then the neutrophils try to catch them, and this may cause an attack of pseudogout. Or occasionally those crystals can layer on top of the cartilage, and on the right side is the ultrasound. We see the typical bony contour, a bright, dark area that is cartilage, and then this bright material that is CPVD material. But there's a little bit where the arrows are, there's a little bit also on top of the cartilage. So then we sometimes be a little bit concerned, could this be gout because it's a double contour sign? But this is fairly rare. This is just another example of the same idea. On the left is a histology slide that shows us a large layer of cartilage, and right inside are the CPVD crystals. On the right lower hand corner is the bone. So is this a concern? On the top now is a table from a large study from 2017 that found a double contour sign in a large number of cases with MSU positive gout, but only in a very small number of cases in CPVD positive controls. So we do not have to be overly concerned about finding a double contour sign in CPVD disease. The specificity is still quite good. In this particular study, they found this to be 92.9%. So what do tophi look like? And we all know from medical school, but also now from comparing with ultrasound, that you cannot really see tophi on radiographs, on x-rays. On the right side is the elbow x-ray of a person. You see really nothing where the blue box is, but on the left is the exact same area that shows us these large kind of ovoid-shaped structures that are tophi. So tophi can be seen on ultrasound, but they cannot be seen on x-rays. And if you cut up one of these samples, it is interesting to see this because those tophi do not exist in complete isolation. You can see on the left image, on the left picture, labeled A, that they are embedded in tissue, in fibrous tissue. And this fibrous tissue is also vascularized, which is important because if you push the Doppler button, we can see hyperemia. If you look on the image B, you can even see that there's some blood around those tophi. So they are embedded in fibrous tissue, and this fibrous tissue is also vascularized. Here's an image of that again. This is again an olecranon bursa, and we see those kind of rounded structures that are bright, that are tophi, and they are surrounded by a little bit of an anechoic rim. And if you push the Doppler button, we see that there's hyperemia in this person's olecranon bursa, although at this point in time, he is asymptomatic. So gout can cause hyperemia or low-grade inflammation, even in persons who we think are in stable remission. So one of the differential diagnoses are, of course, rheumatoid nodules. On the top is a person with nodules in the olecranon bursa. This is supposed to be an elbow here, and this is going into the forearm. Here's the hand. So they are palpable nodules, and then we wonder, well, is this gout? Are these tophi? If we don't really know the patient too well, and we don't have additional information. So rheumatoid nodules look a little bit different. They are darker, as you see here on the ultrasound image. They are these dark nodules. And if you look closely and you look deep to those structures, you can even see that there's some enhancement. So the sound waves can actually go easier through these through this material of necrotic tissue. So that's why they look a little bit brighter deep to these structures. It would be different with tophi. There's a little bit of attenuation. So deep or behind or under these tophi, there wouldn't be a bright signal, but rather a little bit of a darker signal. And this is just the anatomy or the histology, rather. You see this necrotic core of rheumatoid nodule, and then surrounded by these palisade lined or lined up histiocytes typically. This is just a nice image on the right lower hand corner and the top that shows us that a tophus, the crystalline core of the tophus, is really surrounded by cells, particularly macrophages. And you can also see a little bit of vascularity on the histo slide on the right lower hand corner. And on the top, it's not the same patient, but a similar situation. We have a tophus. On the right side, we see a little bit of this anechoic rim that is likely an expression of the cellular material that is surrounding the crystalline core. And then on the top, we have, again, vascularity. This is the same tophus still that we saw in the previous images. And we use a technique that only shows the flow on the top, and on the bottom is a more conventional ultrasound with a Doppler image. And that tells us that there is hyperemia surrounding a tophus, and this hyperemia is really seen in the tissue that is surrounding the tophus, in the fibrovascular matrix tissue. And this, again, is a patient that is asymptomatic in this at this time point. So gout causes low-grade inflammation that we can pick up with ultrasound. And of course, tophi can exist not only inside of joints, but also other areas. This would be a tendon. And then where the arrow is, there are these kind of rounded structures, multiple tophi that are sitting right inside the tendon near its insertion. And if you look closely where the yellow circle is, they even want to erode into the bone. So tophi really have a tendency to want to erode into the bone. and they also like to be situated inside of tendons. Oftentimes when our patients see us or we see them and they have ankle pain and we think this is gout, that can be due to tophi sitting inside of tendons. So what about aggregates or snowstorm? I just put this in because it does show an arthroscopy of a patient on the right lower hand corner, and on the left is the same patient with ultrasound images. This is a knee. The top ultrasound image shows this typical double contour outline of situation of tophaceous gout. We see a bright line of crystals, then a dark line of cartilage, and then parallel to that, the bright outline of the cortex. And then with higher frequency images on the bottom and the middle, we see that there are some bright spots that are located in the synovial tissue. So the synovial tissue picks up some gout crystals, and then they can collect there and aggregate and form larger particles. On the right side, you see crystals in the middle panel, for example, over the cartilage, and the right side, it's a little bit cut off. The right image shows us these small particles, bright spots that are located right on the synovium. And if this situation stays for a little bit, you can even see this on the left lower hand ultrasound image, the synovial tissue becomes a little bit irritated and can become thick. So this can cause this kind of aggregate or snowstorm situation. Snowstorm might be a good term if they are inside of the fluid, and then these aggregates are more in this thickened synovial tissue. There's a couple more examples here. On the top is an MTP joint, and you see these bright spots inside the joint. And on the right lower hand corner is an erosion, and there are still a couple of these bright spots seen that are kind of, I would call them microtophi or small tophi, but aggregates is the official term. And if they swirl around, they can get the snowstorm appearance, create the snowstorm appearance. So here's a big differential. This is even more common than gout. This is osteoarthritis of the basal joint. And it might be worthwhile to look there occasionally. So sometimes our sonographer, when I do the scans, it's me, and I do a hand, I look at the basal joint of the thumb, the first CMC joint. And if there's early osteoarthritis, you can occasionally, like on this slide, you can see a couple of these small calcium crystals being pushed out of the joint into the joint recess. So you can go by location. CMC1, of course, is typical for osteoarthritis. You can go a little bit by appearance. These basic calcium crystals in osteoarthritis, they have more this kind of bead type appearance or grape-like appearance, or sometimes I call this balloons on a string because they're often tethered to the bone, and then they have you see a couple small bubbles. That's typical for osteoarthritis, and the crystals are typically basic calcium phosphate crystals. So what about erosions? It took us rheumatologists, or me or others, a little while to realize that in gout, those erosions are not caused by invading Panus tissue, but it's rather the tophus or the tophaceous material itself that's associated with erosion. And that is because osteoclast-like cells are found at the interface of tophus and bone, and osteoclastogenesis is favored by MSU crystals. So it's really the tophus itself and then the surrounding cells that are eroding into the bone. And here's a nice example, I think, of a tophus. This is a distal tibia. You see the position of the probe in the middle on the bottom there. And the anatomical location with the asterisk is, this will be the distal tibia and the talus and the joint capsule. On top of it is a vein on the ultrasound image. And this erosion is really invading the bone, and there's a bit of a marginal overhang. And if we push the Doppler button, we see that there's hyperemia associated with this tophus. So how does this compare with other modalities? On the top is an ultrasound image of a first MTP joint looking for medial. We see this ovoid or tongue-shaped tophus invading the bone. There are marginal overhangs. In the middle is an MRI study of the same patient, and it's kind of vague, so we couldn't really tell what this really is. So if you look at the literature, and it corresponds often to our experience, MRI studies are not ideal to identify gout. If you want imaging modalities, I would go with ultrasound or even conventional radiographs or CT scans. Or if your insurance allows that or it's available, you can try dual energy CT scan, which is rare here in this country. It's probably rare around the world, but it may become more and more available in the future. So it's good to know about it. On the bottom, you see a typical radiograph that we all know with a punched out lesion and a marginal overhang. This is all the same patient, but this would also be typical, quite typical for gout on the bottom. So what is dual energy CT scan? So we have one, interestingly, at the children's department for our hospital. I'm not sure why they need that, but maybe they get a lot of grant money and they can afford that. So in a dual energy CT scan, the idea is that you use two different energies. So on the left, this is 80 kilovolts. In the middle is 140 kilovolts. Same patient, same location. And you see a little bit of a different attenuation with the lower energy. The bone looks a little bit brighter because it doesn't penetrate as much. In the middle with a high energy, the bone looks a little bit more grayish. But where the yellow oval is, that's where the tophus is located. And it doesn't look like much at all on the regular CT scans, but the computer can look at the difference between the attenuation with one energy and the other, and then can code whatever the computer thinks is tophus with a color, typically green, like on the right lower hand corner, the right panel, rather, the right image. So that's two different energies of the same area, and the difference in attenuation can be calculated into what kind of tissue this is, and this works particularly well for gout. And then it's of course interesting to look at the differences between ultrasound and DECT. So on the top and the bottom are the same patients. The top is of course the DECT, the bottom is the ultrasound. In the little green spots, that's the proximal tibia there. That's where those tophi are. On the bottom, the ultrasound looks just at a smaller section of the whole anatomy, but the tophi look larger. And that's typical for the difference between ultrasound and DECT. So typically DECT underestimates the size of tophi, and on ultrasound they look a little bit larger. Plus you can see the hypoemia on the ultrasound, which you cannot see on DECT. And then you can get these nice 3D reconstructions with the dual energy CT scan on top there. And you can sometimes also see tophi that are not included with the typical protocol that we have for ultrasound. So if you do the ultrasound, of course, we'll ask the patient, is there any other spot that's hurting where I should look to be able to pick that up? And then small tophi or a double contour sign can often not be seen by DECT, by dual energy CT scan. On the top is the ultrasound that shows a typical double contour sign. Same patient, same location in the middle and on the bottom, but you cannot pick up these small layers of crystals with DECT. So ultrasound has some advantages, DECT has other advantages. So in summary, if you compare those modalities, you have to see what's available. What does the government say about in India, as I've heard, about the use of ultrasound? You know, do you have to push a little bit and convince people that this is reasonable and this is very meaningful and cost effective? What is the patient comfort? What is cost? What is the scientific evidence regarding the use of ultrasound? And then you can see these small deposits with ultrasound. You can see a double contour sign, and you can see tophi in their anatomic context. With DECT, if it's available, you get a good overview. You can get a 3D reconstruction, and it's sometimes easier to find tophi that do not include that are not included in our ultrasound protocol. Thank you very much.
Thanks. Great. Absolutely great. In fact, I learned so much. I didn't know that so much is happening. As you become senior, probably you start, these youngsters read much more than the, so I didn't know about this, especially the comparison between the DCT and ultrasound. and your beautiful photograph of that bubbles in the CPPD, which probably I have not seen. So it was all great learning. Thank you so much. I'm very sure there must be a lot of question, and there are a moderator. So let him moderate. Maybe I may leave after 10 minutes. In 10 minutes, I'm with you. And I hand over to my moderator, Dr. Jain. He will moderate the question answer. And let's see that how the youngsters, only thing I was just telling you that time story, that ultrasound versus arthroscopy. You also showed that time, that is about 20 years back. I was learning about the arthroscopy. That was by chance I saw those crystals, which I realized it is already described in the literature called beach ball appearance. I didn't know that. So
you were the pioneer.
yeah. Thank you so much. Great, Dr.
Thank you.
Absolutely superb and very nice slides and great learning in this field, which is, as it is, every day it is becoming more and more exciting, especially the rheumatoid nodules. You described beautifully how it is. It's a great learning for me, at least. I'm very sure these youngsters read much more than me. So I hand over to Dr. Jain.
Thank you, sir. Thank you, Dr. Ralph, for an excellent talk.
And Dr. Jain, I may slip out because I have to deliver a lecture. Actually, I'm sitting outside a hotel.
Sure,
and
sir.
in a car.
Thank you, sir. Thank you for joining.
Yeah. But I'll be there with you for 5-10 minutes. Then I'll go. Yeah.
Sure. So we have a lot of questions, Dr. Ralph. I'll just try to put them into a sort of a series. So first, one question by Dr. Sharad himself. What is the significance of Doppler in tophi? And how does that respect to the presence or significance of Doppler in a tophi? Are they always present, and how
Right. So that's a good question. It depends a little bit on how sensitive the Doppler is. So you have to be a little bit aware of what your Doppler can do. One good way is to place the Doppler over your fingertip, because the fingertip is highly vascularized, and then just tweak your settings so that you can pick up flow in your fingertip. If you just see a large artery, may not be enough. If you crank up the settings and you see a couple of these smaller vessels, then your Doppler might be good to pick up these very subtle areas of hyperemia. But that is a good question. So I think what it does, if you use Doppler, it tells us that there is really increased blood flow, hyperemia, or almost subclinical inflammation in persons with gout. And we know from the literature that the presence of tophi increases the cardiovascular risk. And then we wonder, why is that? But we also know that a chronic inflammatory state is a risk factor for cardiovascular disease. So it's possible that there's a connection between this subclinical inflammation that we pick up with Doppler in gout and other risks involved, such as an increased cardiovascular risk in long-standing tophaceous gout. The other question would be, does it change the immediate management? Probably not. You still want to treat them, but it is satisfying to see that if you treat the tophi, that the hyperemia, the subclinical inflammation, also decreases over time. So if the tophi go away with appropriate treatment with urate-lowering medication, then this hyperemia often improves quite a bit.
Okay.
Dr. Jain,
Yes,
one question, so then I'll leave before I leave. I was really keen. Sometimes acute tophi gives a lot of good Doppler signals when you are doing ultrasound, but the chronic tophi, they don't give Doppler signals. So I was keen to ask his experience. So you can convey this. I don't know, because my video is not working. Yeah.
So it is actually interesting that even in long-standing tophaceous gout, you see more tophi, but you still see hyperemia in these persons. Certainly, if there's acute gout, the hyperemia, the Doppler signal is all over the place. But even in long-standing gout, you think the patient is quiescent or is in the intercritical phase, you still see hyperemia or increased blood flow if you have a sensitive Doppler. For example, I don't know if the slide is still running here, but the right lower end corner shows a person who's in complete remission, and there's hyperemia surrounding this tophus. So even in chronic tophaceous gout, you pick up increased blood flow that shouldn't be there in a healthy person.
I think you showed a slide also for that.
Thanks. Thank you so much. Thanks.
Thank you, sir. One question is in ankle. For some reason, the double contour sign is probably not usually well seen.
That's a very good point.
And there was a question: how do we differentiate whether it's an interface sign or a double contour sign in ankle?
That is an excellent point. So overlying, depending a little bit on your machine, but overlying the talus, we often see a very bright signal between the cartilage and the surrounding capsule. And I've seen this in the literature occasionally that's taken for a double contour sign, but it's absolutely true that you have to take a double contour sign in the ankle with a grain of salt, and you have to be careful with the interpretation. For some reason, I don't see it a lot in the tibio-talar joint. I see a lot of crystals or tophi in the tennis surrounding the ankle. But all I can tell you is gain some experience with your machine so that you can see what does it look like, what does the talus, dome of the talus look in a normal person or in a person that you know doesn't have gout, and what would it look like in a person with gout. So that's pretty much the only joint where I would really tell people or advise people to be careful not to overcall gout, because it can give the appearance of a double contour sign. But I would say gain some experience, see what your machine does and what it looks like in a healthy person. You can look at your own ankle, for example, as a normal, hopefully.
Sure, point well taken. One sort of a complex question. So if you have a patient with coexisting CPPD and gout, I don't know if that sort of situation is there where you have a coexisting patient, how would we differentiate them, what the findings are? And
right. So certainly that's complex, like I said, not entirely easy. You also want to gain a little bit of experience with that. Typically, the crystal layer of gout has this roughness to it. It's not quite as smooth. If we do see a layer of calcium crystals over the cartilage, which can happen, it's often more smooth. It's not quite as rough. But there's not a lot of research or description out there in the literature. So this is something that, we or rheumatologists can still work on to try to distinguish the different appearance of tophaceous material versus CPPD if it is layering on top of the cartilage. But you might see both. You might see crystals inside the cartilage, which are almost always from CPPD disease, and you may see crystals outside of the cartilage, and then you have to differentiate it. Do they look rough to me, or do they look really smooth, which is more what calcium deposits would look like?
Okay. Few questions basically on the role of monitoring, the use of ultrasound in monitoring of gout. Say, when does the double contour sign warrant an increase in persistence of double contour sign, warrant an increase in the dose of the urine-tonic therapy? Is there some logic behind that?
Right. So that is another good question. And I used to think we have to push for making this double contour sign go away in everybody. It can take about 6 months or so, 4 to 6 months. If you really consistently bring the uric acid level down to less than 6 milligrams per deciliter or even lower than that, it takes 4 to 6 months for that to go away, depending on how thick the layer is. But there are some patients that I've been following for 10 years or even more, or 15 years. They're completely stable. They have not had any gout attacks since, but the double contour sign doesn't completely go away. So it is helpful. If it goes away, then you probably have had good success with your treatment. But I would not base my decision to increase the dose entirely on the persistent presence of a double contour sign. So just in some persons, it may be calcified, or and it may still be seen after a while.
Okay, I think we'll take one last question before we go into the case, because we're running out of time. So this is about the double energy CT. So one question from Dr. Soumya Kothari: does the double energy CT pick up acute and chronic tophi with the same sensitivity? Number one. And if I may add, are there patients who are probably ultrasound negative but double energy CT positive? In that sort of scenario, when you're suspecting gout but your ultrasound is not very you're not getting a definite answer, and in that cases, can we do a double energy CT? Will that help?
So you're asking about the dual energy CT scan versus ultrasound. Typically, ultrasound is a little bit more sensitive, particularly for small tophi. Occasionally, tophi are also a little bit more liquid, or the material is more liquid. You sometimes get this milky material when you aspirate joints, and that cannot be seen by dual energy CT scan, by DECT. So you need a certain density of the trophaceous material so that it can be picked up by DECT. So the less dense tophi are seen with ultrasound, but they are not seen with dual energy CT scan. And the really dense ones, they are seen by DECT. And that may be the reason why they look smaller on DECT than they look with the ultrasound machine, because some of that material is less dense and some is a little bit denser. On the flip side, on the other side, typically, or at least in my practice, we have a certain protocol for our ultrasound exam. We say we look at the knee from anterior, posterior, medial, lateral, long and short axis. But if the tophus is sitting outside of this area that our protocol includes, we may not pick it up, but then the DECT would pick it up because it really looks at the entire joint, and you can have a 3D reconstruction and you can pick it up. So that would be an advantage of DECT.
And acute versus chronic tophi, is it the same dual energy CT? The sensitivity?
I think it's the same. The DECT can just not see the inflammation or the hyperemia. That said, both with DECT and ultrasound, the sensitivity increases the longer a person has gout. So after 2 years, the sensitivity is for both modalities is very high. If it's less than 2 years duration, probably because the tophi are small, the sensitivity for both modalities is not quite as good. So the longer you have gout, the easier it is to pick it up.
Thank you, Dr. Ralph, for patiently answering questions. I think we'll just jump on to the case presentation. We have a very interesting case by Dr. Sharath. And over to you, Dr. Sharath. You can present your case.
Dr. Ralph, can you stop sharing the screen?
All right. Okay.
Thank you. So this is a patient who I saw very recently and had an interesting finding, and that is why I thought I would present it here, and I would like your inputs as well, Dr. Ralph. So this patient came to me sometime back. That was in September 2016. That time, she initially presented to the medicine department. She had pain and swelling in the hand, and that appeared to be infective tenosynovitis. She improved with NSAIDs and antibiotics, but as soon as she was admitted, there was a whole lot of tests which were done, though it was an acute history. And among the tests, it was seen that she had a high titer rheumatoid factor positive. She had high titer ANA positive, 320, and she was Rho52 positive. The complements were normal. The Shermers was also normal. Serum globulin was slightly high. So given the fact that she did not have any objective or subjective manifestations of oral Zika, and only the serologies were this thing, I thought that even with difficulty, I could not make any diagnosis other than UCTD, which would also require some clinical manifestations, which she did not obviously have. So I thought I'll follow her up, and I kept her on hydroxychloroquine. Shortly afterwards, she was diagnosed with breast cancer, and she was started on chemotherapy. Once she completed the chemotherapy, she again reviewed with me, and that time she was having a lot of aches and pains, which were mechanical in nature. She did not have anything on examination. When I reviewed the medication she was on anastrozole, which is an aromatase inhibitor. And as we know, aromatase inhibitors themselves can cause a lot of arthralgia. So I thought that must be the reason. And since it was not really affecting her daily life, I thought I'll just keep her under observation, and I continued on hydroxychloroquine. She did not have any evidence of inflammatory arthritis or tenosynovitis. She just had plantar fasciitis, one episode of posterior tibial tendonitis, and she just used to review once in a year or once in 6 months. But this February, she had pain in the right shoulder, which was moderate and subsided after 3 to 4 days. But on 28th May of this year, she had severe excruciating pain in the right shoulder, which was sudden in onset, and she was not able to move at all. And she had only partial response to NSAIDs. So she went to the orthopedician, who asked for an X-ray. And then subsequently, he said that MRI and PET-CT might be done because he suspected metastasis. However, the oncologist disagreed with him and asked her to review with me once. So this was the X-ray which was done. It was reported as a normal X-ray. And when she came to me, she came with the routine labs, which would be done once in a year for her. And the ESR was quite high, and the CRP was also significantly elevated. So in any other normal situation, I would have thought that, okay, she has finally manifested probably her undifferentiated connective tissue disease, though the way and the severity of the arthritis was very odd, and the single joint involvement was also very odd. So that was the odd point, which was, which I felt needed to be evaluated. So that is why I decided to do an ultrasound. Otherwise, I would have probably started her on some steroids and started her off on methotrexate as well. So this is a picture from the literature. So this is the ultrasound probe. When it is kept in this way, you can see the humerus and you can see the supraspinatus and the deltoid muscle. And this is the subacromial subdeltoid bursa. And this is the acromion. So this is the image of the patient. You can see the supraspinatus, the deltoid, and the subacromial, and this is the humerus. And here you can see this big fluffy ball of deposits, which there were 3 of them, one really big and the other 2 small ones. And in the transverse view also, you could see that they were sitting over there. This was the big one, and this was one of the small ones. So based on the location of the deposits, the nature of the deposit, and Dr. Ralph will correct me if I'm wrong, but I thought that this was typical of BCP deposition disease. So I started her on colchicine, and with that, she improved dramatically, and she's doing very well now. If she had gone in for MRI, as Dr. Ralph had also pointed out, MRI would really not have picked up crystal arthropathy, and its utility in BCP as well is quite limited. When I went back and I saw in the X-ray, I could actually see the calcium deposition over here. So all of us rheumatologists are like in medicine, we are taught that when we hear hoofbeats, we have to think about horses and not about zebras. But in rheumatology, sometimes we have to think about unicorns as well. So, Dr. Ralph, your comments, please.
I think you handled this case very well, and I'm very impressed. So you're absolutely right that typically, if it's in the shoulder, it's basic calcium phosphate. Often it's hydroxyapatite that is causing this, and that can cause episodes of extreme joint pain, particularly in the shoulder. So this is really what that looks like, and then certainly using colchicine is the right choice. Interestingly, this happens more in sedentary persons. This condition, we think it's from physical labor, but it's actually not. And for some reason that is a little unclear to me, these lesions can even resolve spontaneously. Sometimes people even go in with the needle under ultrasound guidance and try to break them up and then get some of that material out. But if this patient is doing better with colchicine, I think I would wait with that and just keep monitoring her. The other question is this even be connected to either her history of cancer or the history of this undifferentiated connective tissue disease, or if this is a separate issue that she's having?
So that was going to be my what you answered was going to be my next question. That what is the timing and when would you actually think of doing barbotage in these kind of patients? So you would not do barbotage, you would just wait and observe, is it?
If she's asymptomatic now, I think I would wait and observe, yes. If she gets frequent attacks, and these attacks, as you mentioned, can be very painful and excruciating, then I would do this for symptomatic relief, and then I would, just like you saw in this example from the literature, go in with a needle and then use lots of anesthetic, lidocaine or xylocaine, what you use, and then try to go into this tophus, and then you can even inject some of the lidocaine into this material, and then try to break it up, and then aspirate as much as you can get out, and then give the patient NSAIDs and hopefully, and sometimes a little bit of physical therapy once this has resolved, and they often do well.
Okay. So in fact, I reviewed the literature after I saw her. I could not find any connection between undifferentiated connective tissue disease or breast cancer, or even the medications that she was using versus the prevalence or incidence of BCP disease. So probably something that we need to watch out for, and if we see more patients, maybe something that we could think about. But
Right.
this is the first such patient I came across.
Excellent case, and she looks like she's a relatively typical patient. So it's more in, I think, patients between 40 and 60, women a little bit more than men. People who are not manual laborers, for some reason they get this more often than people who are very active.
Okay, so I think there are some more questions. If we have some time, can we just take that up? One or two questions more. Ralph?
Oh, yes, please.
Sure. Yeah, one of the questions was about the double contour sign, the location of where we want to look, say, suspected in uninvolved joints. So if there are some studies also, probably patient, if the particular joint is not involved, is it worth looking for, say, to look for double contour sign if it's not found in the typical sites? Say if patient does not have knee pain, but you also suspect gout, and is it worth looking at or certain joints are more specific for double contour sign?
Yes, so it is. I think it is the usual suspects. So you see this particularly in the toes, I would say, and as you mentioned, also in the knee. So often I do a screening ultrasound of the first and second toe. So I look from dorsal, from medial, and then from plantar at the first and second MTP joint. And I include the second because sometimes in the first you have the two sesamoid bones in the way, and you may not always be able to see the metatarsal head nicely. So I typically either tell my sonographer or do it myself. I also look at the second MTP joint from the plantar aspect. So those are good areas to look at. You can look at tendon insertions, particularly the patella tendon and the Achilles tendon. You can get tophi inside these tendons. So those are good areas to look at. So I would still say that the great toe, the second toe, the knees, in the olecranon bursa, you can palpate if you can feel tophi. So those would be my recommendations. I don't see a lot of gout in the shoulder, I have to say, so I would not include this in the screening ultrasound study. I don't see that much in the actual elbow joint. I obviously see more in the olecranon bursa. So knees, toes, bursa, and then Achilles tendon, and then patella tendon, possibly the quadriceps tendon also. They are high yield areas.
Okay, so I think we have covered most of our questions.
Can I ask one question?
Sure.
Vikram? So, Dr. Ralph, have you, in a couple of patients at least, I've seen that I was able to make out the double contour from the plantar side, but not from the dorsal side.
Oh,
so
yes.
Is there any literature or your experience with respect to differences in sensitivity from plantar versus dorsal?
I think this is literature that we still have to work on to establish. But I have to say I see this a little bit more from the plantar aspect than from the dorsal. One of the reasons could be if you look from the dorsal aspect, you just don't see as much of the cartilage as you would see from a plantar aspect, just because the cartilage just starts here when you look from dorsal, but on the bottom of the plantar aspect, it really goes it wraps all around the metatarsal head.
Thank you.
Okay, so if there are no more questions, I think we'll end the session. Sharath, you want to make any announcement?
So this is, as I was telling Dr. Ralph, so this is the first meeting for the special interest group of musculoskeletal ultrasound. And I've circulated an email ID. So all the people who are interested in joining the special interest group so that we can further musculoskeletal ultrasound in India, please do drop an email to that email ID. And we'll send you the link to the meeting so that we can meet regularly and plan further initiatives. So with that, Vikram, you can.
With that, I think we'll end the session. Thank you so much, Dr. Ralph, for agreeing to speak to us. I just put in a mail and he answered. Thank you so much. Thank you so much for giving a very lucid and excellent talk. I think for us as rheumatologists, ultrasound, the first thing which we learn is the double contour sign, and you're the first person probably to describe that. So it's been a pleasure. It's been an honor to have you with us today and taking time out and sharing your wisdom on the role of ultrasound in crystal arthritis. Hope to have you often and to share your knowledge with us, and hope to connect with you frequently. With that, I would like to end this session. Thank you so much, Dr. Ralph, again. Thank you, Dr. Sharath, and thank you all the attendees. We had more than I think 30 attendees on this Zoom platform, and then we had people on YouTube also watching all over the country in India. So it's been an excellent session, excellent learning for all of us. With that, I would like to end the session.